Hey, hello. This is the live that we're meant to be doing with SFS, IVF, and Dr. Daniel Marcu. I can just invite them, I think. Amazing. I can see people are joining. Accept. Okay. Okay, I'm getting the hang of this. The hang of this. Yep, I think I've accepted Dr. Marcu as well. Something's happening. Something's happening on my screen. Amazing. Loads of people are joining. Thank you so much. Welcome. Um, Maybe there's some connective issues. I'm not quite sure what's going on. But loads of people are here. Thank you for tuning in. Oh, someone left. Okay. Maybe I can invite them again. Let's see. Okay, I have invited him. Hopefully he can join again. Hello, can you hear us? Technology, this is going great. Let me invite SFS again, and hopefully this can work. Fingers crossed. Okay. We're missing some people, but thank you for everyone who's joined. It's really great. We are very excited for this talk. We're going to be, as you may have seen, we're going to be talking about male fertility and infertility, more so the basic kind of biology, getting to see how we get to the stage where we're actual walking people, you know, walking around. So Dr. Marcu is really, really great on this topic, really passionate. He actually taught me when I was at UCL, so it's really great to be able to collaborate with him today. And, you know, I just want to say a massive thank you to him for agreeing to come on and share his knowledge with us. So, yeah, if you want to know a bit more about him. Ah, there we go.
Hi, Emilia.
Hi. I was just singing your praises.
Yeah, I'm glad I managed to join. I was just listening to your kind introduction, which is fantastic. But I'm glad I managed to join now.
Amazing. Yeah, it's great to have you joining us. So for those who don't know, Dr. Mark is a PhD researcher, and it's all about, you know, sperm health and how we can use that knowledge to improve our diagnostics in the clinic and for patients and improving IVF outcomes. And of course, if you want to add anything, then, you know, you're welcome. Can you hear me okay?
I can hear you. Yeah, thank you very much for having me.
Amazing. Yeah, so we'll be talking about, as I've said, male fertility and infertility. And I just want to start with how you got into the field of men's health and why you think it's so important to raise awareness around this topic.
Sure. I get asked this question all the time, as you can imagine. I think what drew me into this field was really my innate scientific curiosity to look at things where other people were not looking at. And certainly, you know, I've been around for the past 7 years, 7 or 8 years. And back then, you know, early 2016, 17, 18, nobody was looking at male fertility or men's health as a whole. Um, from a research perspective or a commercial perspective altogether. And I think what really sparked my curiosity was really probably the same reason that sparked yours. So was really UCL. So I did my master's in prenatal genetics and fetal medicine at UCL, and that for me was fascinating because for the very first time, you know, I was going home and I was telling my friends, people, what I was learning and how relevant that whole information was. And I was seeing adverts on London Underground about what we're learning, and it was just fascinating. But I think something that I was puzzled about was the fact that I was learning very I guess, complex information about women's health, fetal medicine, genetics. But there is very, very, very little about male fertility. In fact, I think the only moment when we would talk about male fertility was really when we would talk about genetics, and the conversation was limited to the fact that men contribute to 50% of genetic information to the egg, and that was the whole process. But then, in all fairness, it was the Institute for Women's Health, so I don't understand. Exactly, I don't understand the point. But then I think that led me to kind of try to find answers for myself. So after my master's at UCL, I moved to the east of England, to the University of East Anglia, and there I started to work on a PhD in sperm biology and genetics. And I think over this so my PhD was almost 5 years. Over this 4 years and a half, this is where I really fell in love with the topic, and I understood, how little we know about it all and how much work there still needs to be done around the topic. My project as a whole really looked at trying to understand what makes a sperm good enough for fertilization and what are the biomarkers linked with sperm fitness and embryo development and things like that. And I think, it's more than ever is extremely relevant because we see it all over the news that sperm counts have declined drastically. And the more I talk with people, the more I realize that actually very few understand how widespread male infertility is and how men's lifestyle choices could be putting their partner through IVF and invasive procedures. So that's why I really think that it's worth us talking about this, and it's worth scientists and researchers and doctors continuing the conversation and doing research on the topic.
Yeah, and I think as well that kind of links as well to the whole stigma around fertility treatment and how historically it's, the woman and the woman's biology, but actually as people are starting to speak up and our technology improves, we're finding out that it's not just one person's side, it's, really a 50-50 kind of equation.
Exactly.
So kind of going back to a really basic thing, and everyone's how spermatogenesis works and how we kind of arrive here.
Yeah. That's I feel like that's probably like an hour-long lecture. But as a summary, spermatogenesis is really the process that leads to the formation of fully mature gametes, or sperm, what we call sperm in layman's terms. And I guess to kind of illustrate that and to give you a little bit more detail on that, the process happens in the testicles, and the testicles sit about 2 degrees lower than our core body temperature, and that's really necessary to make sure proper sperm development and that sperm are basically kept healthy while they are waiting to be ejaculated outside the body. Now, the testicles themselves, they have 2 main jobs. One of them is obviously to produce sperm, and sperm production happens in the seminal tubules. So if we imagine this is a testicle, sperm production happens somewhere here, right? And we as men, we have hundreds, we have 700 plus 700 of these tubules inside each of our testicles. So this is a continuous process. Now, when all the sperm are ready to be stored. So once they are produced inside the seminal tubules, then they are ready to be stored. And from the testicles, they move to another compartment, which we call epididymis. So epididymis is the structure that sits on the top of the testicle. So if this is our testicle, this would be the epididymis, right? So they would migrate to the epididymis, and they will acquire motility. So one important thing that we have to understand is that while sperm sit inside our reproductive system, they cannot move. So they rely mainly on the contractions of our ducts to essentially move from one compartment to another. And so once they reach this region, they remain dormant and they gain their fertilization ability. So they gain that motility that we all know about. And once they're ready to be ejaculated, then they move from the epididymis to outside the body. And then, the process starts. Now, what's fascinating, I feel, about spermatogenesis that nobody's talking about is the fact that the whole process happens and starts in the brain. So in the brain, we have a lot of different organs and structures, but one of the most important ones that is highly relevant for our ability to reproduce and to drive our reproductive success is the hypothalamus. So the hypothalamus is a structure that we have in our brain, and it controls several functions such as regulation of our body temperature, regulation of our reproductive system. And what that hypothalamus does basically is that it tells our hormones to go to the testicles to produce testosterone. And once testosterone then is produced, then the whole spermatogenic cycle begins. Just to illustrate that a little bit more, so yeah. Spermatogenesis has three main, so after this hormonal cascade that we have that initiates in the brain, spermatogenesis has three main big steps that we have to be aware. I feel like everybody needs to know that. The first step is that we have stem cells, so everybody has stem cells, and testicles themselves, they have their own stem cells. And the first step in the whole spermatogenics process is for those spermatogenic stem cells to grow and multiply. Essentially, that's their only job. So this is the first step. In the second step, what those cells, at least what some of those cells need to do, is to divide their genetic information, because we know that we only need 50% of DNA from the sperm and 50% from the egg. So that division is really necessary to ensure a fully competent fertilization event and a fully competent embryo, essentially. And the third phase of spermatogenesis really involves restructuring and changes of that shape that we know as fully mature sperm. So we have to imagine that once those sperm are in the female reproductive tract, they have to be fully capable of swimming, of resisting stress, to make it to the other side of the female reproductive tract. And in order to enable that, those cells, they have to condense their nuclear DNA as much as possible, because otherwise the female reproductive tract sees those cells as invaders. So we have women have a lot of leukocytes, bacteria, that they attack the cells. The first thing they do is attacking the cells. And when the nucleus is compacted, one is that it resists to all this damage, and second is that it enables the sperm to gain that hydrodynamic shape, essentially, to swim up.
Yeah, I mean, it's definitely a long journey. So, you kind of alluded to some of the aspects that help sperm achieve the goal of fertilization. So when sperm quality and sperm quality parameters and how they help in conception. So I was wondering if you could comment on a bit more about that and what exactly those parameters are. What are we looking for?
Sure. So I think what we mean by parameters that help in conception is that we refer to things like to measurable features, essentially, that can predict fertilization success. And in order to assess a semen sample comprehensively in an andrology lab, we tend to look at things without a microscope. So this is what we call macroscopic assessment, so macroscopic features. And we look at volume, we look at viscosity, color, and pH. And this is really important because it gives us an understanding about the biochemical composition of that seminal fluid that is required to propel the sperm into the female reproductive tract. Then when it comes to sperm-specific aspects, we need microscopes, or we need molecular technologies to look at three main things: numbers, so how many sperm we have; motility, how many of them are moving; and then morphology, how are they shaped, essentially, how do they look like. Now, all those parameters, they have and are linked to WHO criteria and specific thresholds in a typical fertile man. So based on that, then we're able to base our clinical decisions and either refer the man to a urologist or then establish a diagnosis that way. We know that for natural,
Oh, no, go ahead. I was gonna
Sure.
say.
We know that for natural conception to happen, we generally need a reasonable amount of concentration and a reasonable amount of decent moving cells. In terms of numbers, we know that men that have less than 60 million sperm per milliliter, they generally take a bit longer to impregnate the partners. But numbers only matter up to a certain point. So we know that the chances of pregnancy increases up to 50 million per milliliter. If the man has more, then the chances remain the same. So it's, you know, if you have more than 50 million, it doesn't really matter. For assisted reproductive technologies such as IUI, IVF, we rely more on motility. So for intrauterine insemination, for example, we need to be sure that those cells have at least 40% motility after the sperm have been prepared in the lab. If that motility is not there, then we would have to do IVF. If motility concentrations are impaired, affected, and abnormal, then ICSI is generally the last resort, which when we pick a cell and inject it directly into the egg.
And we will talk about more of these things. You know, we're not just throwing terms at people. You know, we will go into it. So I was just wondering. I mean, we've kind of spoken about it, but before we move into the causes and the factors that affect male fertility, how would you medically define?
So male infertility as such is really the male contribution to a couple's inability to conceive after 12 months of unprotected intercourse, or 6 months if the couple is, or if the woman is over the age of 35. Now, we generally look to identify male infertility, we generally look for abnormal seminal parameters in at least 2 tests to make sure that the results are consistent, or we look for evidence of hormonal issues, genetic abnormalities, or anatomical issues in the testicles that impair sperm production and sperm transport, essentially. We know that the main cause of male infertility as such tends to be around testicular defects that impair sperm production. So these are things like varicocele, these are things like undescended testicles, infections that tend to compromise our testicles' ability to produce sperm, essentially. And so when a condition is identified, then, you know, diagnosis is made that way.
Okay, amazing. Thank you for that. So I was also wondering, maybe, you know, people wonder, can I do something like this? What really is it? So maybe some environmental factors that could be affecting males and they just don't know, or could change something in their lifestyle and help that production.
I feel like this is such a relevant question because we see a lot of talk recently about it, and this is certainly something that we looked into it a fair level of a fair amount of time. Now, at least the research we've conducted and what we found was that a lot of toxins that are currently found a little bit everywhere, actually. So in personal care products, in pesticides, so, you know, pesticides that food are sprayed with, pharmaceuticals, and things like that. What we know is that they are generally the molecule making those compounds tends to be very, very small. So what that means is that in a lot of the cases, that molecule from all these toxins can bypass the blood-brain barrier and can bypass the blood-testis barrier. So what that means is that if it bypasses the blood-brain barrier, then it can interfere with the hypothalamus and with all that hormonal changes that we talked at the beginning. And if it targets the testes themselves, so if it targets the developing spermatids, then that could lead to compromised motility, to compromise fertilization success. So these are, you know, exposure. So exposure and occupation are major things, but also stress. I think people neglect, and certainly people that are in a fertility journey, they know very much how stressful this journey is, and it doesn't help to say, you know, just relax, because it doesn't work that way. But stress is really a trigger point, because once again, it triggers our hypothalamus to block the release of those key hormones necessary for fertilization. And that would then compromise their chances of conception.
Yeah, cool, thank you. Female age, on fertility, and how important that is.
I lost
because I think we lost connection there for a bit.
I lost this. Like, was this about age and how important age is?
Yes, because we hear a lot in the clinic about, advanced maternal age and fertility, all the socially on to preserve female fertility. But I was wondering how important male age is on fertility treatment.
Yeah, we now have quite a lot of evidence that actually suggests that age in men is equally important. Perhaps not as the decline is not as pronounced as in females, but it's definitely something that we need to be aware of. Based on large-scale studies, we know that the prime age for a man to have children is around between the age of 25 to 30. So this is when their men's fertility peaks, really. As advanced maternal age, on the other hand, what we know is that it can lead to increased risks of autism or schizophrenia. And when I'm talking about advanced maternal age in this context, I'm talking about men older than 40. So the risk is small, but there's still a small risk. Now, there's a biological and environmental explanation for these two things. Biologically, we talked about it at the beginning. So the way that sperm develop is through stem cells, right? So those cells have to divide. And what we know through research is that the more the cells divide, the more mutations they accumulate, the more genetic errors they accumulate. We know that in a 20-year-old man, for example, the amount of time those cells replicate is about 150 times, whereas in a man aged 40, that number jumps to about 600. So there's a lot more cellular divisions happening, and with more cellular division, we risk introducing genetic mutations. And some of these mutations are completely harmless, but others might be harmful. And then when we expose our body to toxins that interfere with all this biological process anyway, then this is when we see the effects that we see.
Yeah. So what I'm getting is kind of that obviously, we have all these exposures that we can't really extend. I mean, we can, but also that we can also have an active role, or men can have a role in trying to improve their fertility and the outcomes of conception treatment.
Exactly. I mean, especially just to add, especially because we are extremely fortunate, because whilst women's egg reserve, declines significantly, men we produce sperm every 3 months. So there's a real opportunity to really work on lifestyle factors to optimize them as best as possible to make sure that new sperm reserve is as healthy as possible.
I lost you there for a bit. I think I'm back now. Okay. Yes. Yeah, can you hear me?
Yeah, I can hear you.
My connection. So yeah, when let's say we have a couple, they come into the clinic, and we're going to talk about assessing their patient's sperm quality. I was wondering, we hear about our DFI, DNA fragmentation index, and the Zymot. So I was wondering if you could explain those a bit and comment on them.
Yeah. I think what's really important for perhaps for the audience to understand is that they fall into two different categories. So we generally use DNA fragmentation in the context of informing a potential diagnosis. So it's almost like a diagnostic test. And we use microfluidic platforms like Zymot and many others as an interventional tool. So I think that's the first key difference between the two. Now, when it comes to DNA fragmentation, this is a test that looks at the DNA and the genetic material that is found within the cell. And what we know from research is that high level of fragmentation levels generally means that those cells have compromised fertilization ability. Now, one caveat to all the DNA fragmentation technique is that there are several methods that one can do in the lab, and they all have quite different clinical thresholds and interpretation. And as a result, the DNA fragmentation test as such should not be used as should not replace basic semen analysis, but should rather be used as a tool to supplement any other clinical history, scans, and basic semen analysis. I think this is the first thing to consider. Then we have the microfluidic platforms that you mentioned. These are tools that are able to help couples and men select the best quality sperm out of many millions of cells we can inject it. And the promise behind those platforms is really to mimic the female reproductive tract as much as possible and to create that environment full of obstacles so that only good quality cells are able to be collected at the end of the process. We know from research that the efficacy of such devices tend to compare quite nicely with traditional methods such as swim up, for example, when we just add some culture media to the top and we wait for the cells to swim up for about 45 minutes. And we certainly know that microfluidic platforms can help reduce oxidative stress and DNA fragmentation level, mainly because there's no centrifugation involved, and you know that's a good sign. But one thing to consider amongst DNA fragmentation and microfluidic sperm selection is that these techniques are useful, but they are not useful on their own. So people and men should still do their job and at making sure that they optimize their fertility as much as possible, so that this technique can actually do their job as much as possible too.
Definitely. So, okay, we have this couple, they've come to us, you know, we've done all these techniques and assessments. So I think it's important to know that there are things that we can do in a case maybe there's just male factor infertility, or you know, there's a sort of issue with both parties. So you also mentioned that earlier, IUI, intrauterine insemination, ICSI. So yeah, just maybe explain to us what kind of these things are that are offered in a lot of fertility clinics and are. So yeah.
Yeah, sure. So depending on the couple's history, first of all, I think, you know, we've got to understand the couple as a whole and how they present to the clinic, and depending on their history and depending on their laboratory results, then a intervention plan would be made. So if from at least from the men's side, if motility is fine, if the woman doesn't have any abnormalities with her fallopian tubes, and if the uterus is receptive to implantation, for example, IUI could be offered. So we would just wash sperm in the lab and make sure that we deposit highly concentrated amount of sperm cells in the woman's uterus, essentially. And that would hopefully lead to fertilization should the woman ovulate as she would every month. Now with IVF, this is obviously a technology available to fertilize eggs outside the body. So we would collect eggs from the female, sperm from the man, and we would fertilize the egg in the lab and wait for about 5 days before we transfer back the embryo. But this, once again, there's assumptions that the sperm quality is satisfactory, so that we have good motility, that we have good morphology and good concentration. If those conditions are not met, then we would need to inject the sperm directly into the egg and hope for fertilization. If there's no sperm altogether, then there's other surgical methods like going inside the testicles and aspirating testicular tissue or aspirating cells directly from the testes. So depending on a couple situation, then there's different protocols to be followed.
Definitely, all going into the other structures you mentioned, the epididymis, and
exactly.
Again, depending on what the specific issue that we have is. So yeah, just to summarize, we've gone through the basic biology and how we use that in the clinic to help us make decisions, and that although there are maybe some things that we can't avoid, you know, we can still have an active role in improving and maintaining fertility and helping IVF outcomes or natural conception outcomes in any case. So yeah, I don't know if you have anything else to add, a highlight that you want people to keep. We've gone through quite a lot of things in a very short amount of time.
Yeah. I think it's been great, and I'm very optimistic because I feel and I see many couples being certainly when they embark on this fertility journey, they get educated really fast and they start asking the right questions. And this is something that we certainly haven't seen, you know, many years back. And now people are challenging us scientists and are challenging doctors and asking all the necessary questions. And this is the first step, really, is making sure that you have access to good quality information to be able then to make your decisions, be that whether you want a kid or you don't want children altogether. So I'm extremely positive about where we're heading. We have amazing new technologies being constantly developed. We have great scientists and researchers. The field is growing. So I think we just need to keep push forward and make sure that we support everyone on this journey.
Yeah, and you'll have the opportunity to talk more about these emerging technologies. I know I've heard of some of them at my professor. Very, I mean, kind of like a sci-fi moment of okay, but really, really interesting still. So yeah, in our next session together on the 20th of November. So yeah, you'll have a chance to explore that more with Dr. Zervomanolakis. So that's going to be really, really interesting to see. And yeah, from my part, thank you so much for joining us today and giving us all these incredible facts. And I'm sorry about the connection issues, the typical all the time.
Yeah, no, thank you so much for having me, Emilia.
Thank you. Okay, have a good rest of your day. And thank you for joining as well. And if you have any questions, please let us know and we'll be happy to answer.
Yeah, absolutely. Absolutely.
Thank you so much. Bye.
Bye. Bye-bye.